Hello, everyone. My name is Maria Serna, and I'm International Coordinator for the uh, American Academy of Otolaryngology, and I want to welcome everybody to Global Grand Rounds. And this is our first Grand Rounds of 2025, and we're very proud to do it with in collaboration with the Canadian Society of Otolaryngology and Head and Neck Surgery. And today we will be talking about discussing challenges of controversies in pediatric otolaryngology. So this has been very well attended by people from all over the world, and we're very happy to mention that about 1,409 people from various parts of the world have registered for this Global Grand Rounds, and very impressed that there are about 122 countries that are participating in today's event. So we have a very exciting program and experts in the field and to discuss the topic, which will be followed by a Q&A, and where you will be able to address some of the questions that might arise during the presentations. And please use the Q&A section in the like on the bottom of the screen. You can actually enter your questions, and some of them are going to be answered live, and some of them are going to be answered in the chat box. So first, I would like to introduce Dr. Troy Woodard, who is the president of the American Academy of Otolaryngology and Head and Neck Surgery, to give a few remarks. Please, Dr. Woodard.
Yes. Good morning, and thank you, Dr. Serna. I am thrilled to be here. On behalf of the American Academy of Otolaryngology and Head and Neck Surgery, it is my honor to welcome you to today's Global Grand Rounds. As was mentioned earlier, the topic is on the challenges and controversies in pediatric otolaryngology. I'm excited because we have over 1,400 physicians from all around the world registered for this weekend's webinar. And in my opinion, that in itself speaks volumes about our shared commitment to advancing our specialty. I want to especially thank you, our colleagues from around the world. Many of you are tuning in late in the evening, or depending where you are, it could be very early in the morning, and your dedication is inspiring. I also like to recognize Dr. Cern and our global leadership team for assembling such an outstanding panel of pediatric thought leaders. No matter how long you've been practicing, today's presentations and discussions will be educational and thought-provoking. On a special note, I would like to send gratitude to our Canadian colleagues and the Canadian Society of Otolaryngology Head and Neck Surgery for partnering with us on this program. The Academy places great value on this relationship, as well as ongoing collaborations with all of our international corresponding societies. Together, through the partnerships like these, we can advance our specialty in ways in which just no one society can achieve. Again, thank you so much for attending, and I look forward to today's program. I'll turn it back over to you, Dr. Serna.
Thank you, Dr. Woodard. I would like to also introduce our Executive Vice President and CEO of the American Academy of Otolaryngology and Head and Neck Surgery, Dr. Rahul Shah, for further introductions and some of the remarks on behalf of the Academy.
Thank you so much, Maria. All 240 of you that are on, take a moment and let us know where you are from all over the world. This is the most exciting time for me every quarter to see where our guests and our members are coming in from. I see El Salvador, Nepal, Mongolia, Malaysia, Spain, Oman, Romania, Philippines. I can read fast. Arabian Peninsula, India, Italy. It's absolutely stunning. Thank you, thank you, thank you. Also would like to acknowledge Katie Stokes-Grimes and Elise Swinehart from our internal team. They do tremendous work with Dr. Serna behind the scene. I'd like to thank our presenters. Most importantly, I'd like to thank you all, carving out time from your Saturday to join us in the global community. These 4 talks are the best you'll find. As I told the presenters, this is the broadest reach they'll ever have in their career. We have 3,000 of you that watch this all over the world. Thank you, Sanjay from Atlanta, Georgia. I can see Jamaica. I get so excited. Just keep telling us where you all are from. The global community, Kazakhstan, is truly amazing. I'd like to pause for a moment and acknowledge my friend, Dr. Sam Daniel. He's an absolute legend. Take a moment to read his biography. He's one of those people we met early on in our career and we just hit it off. We're exactly the opposite. He is thoughtful, pensive, a true academician, and a great leader. You can infer how I am if I'm the opposite. We've got along terrifically for the last 2 decades with mutual respect. At the Academy meeting in Miami, shaking hands, we realized that the American Academy and Canadian Society are real partners. And this is the beginning of the partnership. On behalf of Dr. Daniel and the Canadian Society, I implore you to join me. We'll all be in Fredericton, Canada, May 30th to June 2nd for the Canadian Society of Otolaryngology. Without much delay, gratitude to you all, and I'd like to introduce Dr. Sam Daniel. What a pleasure, and thank you for putting this wonderful program today on for us, Dr. Daniel.
Thank you so much. The pleasure is mine, and I'm very excited to be here. As the president of the Canadian Society of Otolaryngology Head and Neck Surgery, I come with a lot of gratitude. Dr. Shaw, you're a leader and truly inspiring, wonderful human being, and it's thanks to the great person that you are, to Katie and her wonderful team, as well as the panelists you see today, that we have this historic event. It's really historic and an important one. It is going to lay the foundation for collaboration moving forward, because it is through knowledge, collaboration, advocacy for our patients that we are united together. Great thanks to Dr. Surna, Dr. Chelius, and Dr. Woodard as well. Much appreciation. I was asked to say a couple of words for the audience here about the Canadian Society, and I'll be very brief. For those that don't know, the Canadian Society of Otolaryngology, it was founded in 1946, so almost 80 years, by 3 otolaryngologists. It organizes an annual meeting, and it owns the Journal of Otolaryngology Head and Neck Surgery, which is available online as open source journal. It also supports many initiatives with a mission to be the national voice of otolaryngology head and neck surgery in Canada, as well as provide leadership and support to its members and the public, and promoting and fostering international collaboration and communication amongst stakeholders. There are many subspecialty interest groups that you see on the slide, 13 accredited programs. And something interesting to share with you is we've modulated our training program to be based on competency rather than a time-based model, which was a traditional 5 years of training. I invite you all to come join us at the annual meeting of the Canadian Society in Fredericton, where the theme From Heritage to Horizon, the Power of Coaching, Mentorship, and Connections, May 30 to June 2nd, 2025. And I'm here with you today to celebrate these connections with a lot of gratitude, and look forward to an exciting panel. Thank you.
Thank you so much, Dr. Daniel. Moving on, I would like to introduce you to our moderators for the session. And we have experts in the field, and I'm really, really honored to be part of this meeting and lead this Global Grand Rounds with Dr. Daniel Chelius and Dr. Liz Graham. Dr. Chelius is an associate professor of otolaryngology at Baylor College of Medicine, where he specializes in pediatric head and neck surgery and thyroid diseases, and he practices at Texas Children's Hospital. I've been honored to work with Dr. Chelius in multiple leadership roles. He has been very active in the American Academy. He's a recent coordinator for the American Academy Head and Neck Surgery annual meeting. He's been doing a phenomenal job between the years 2021 and 2024. So all of the wonderful panels and all the wonderful speakers that you saw at the meetings, that was majority of what was coordinated and put together by Dr. Chelius, which is really, really appreciated. He also was recognized by Women Otolaryngology with a He for She award in 2023. It's always been a pleasure to have Dr. Chelius as a colleague, as a mentor, as a friend. So we're really excited to have them at this global grand rounds. Dr. Elise Graham is a pediatric otolaryngologist and head and neck surgeon at IWK Health Center in Halifax, Nova Scotia, and she's an associate professor at Dalhousie University. She is mostly interested in airway, feeding, swallowing disorders, and has a lot of experience in like in surgery and medicine. She has lots of peer-reviewed publications and book chapters, and also a fellow of Triological Society since 2024, where she received with the Distinction Award for her research and thesis. So welcome, and I'll let the moderators continue with the program and introduce the speakers.
Thank you so much, Maria, and thank you to both the American and the Canadian societies for the chance to moderate today. On behalf of Dr. Graham and I, we join you attendees excitedly to see some people that we really admire speaking about pediatric otolaryngology. And we have to say that seeing where you are all from, we can say that there are 1,400 attendees registered, but to actually see where you're coming from this morning is heartwarming. To see the global otolaryngology community here together. So without further ado, we will present our panelists today. We are so lucky to have two world experts in pediatric ear care with us today, Dr. Sharon Cushing and Dr. Sam Daniel, as well as two real-world experts in pediatric head and neck care, Dr. Vincent Couloigner and Dr. Amy Dimachkieh. Elise, I'll turn it over to you.
Great, and I'd like to invite Dr. Cushing to start loading her slides while I get the honor of introducing Dr. Cushing. Dr. Cushing is one of my two Canadian colleagues on the panel today, one of my great role models. So I'm really pleased to be able to introduce her. Dr. Sharon Cushing is a pediatric otolaryngologist at the Hospital for Sick Children in Toronto, Canada, as well as a professor and clinician investigator in the Department of Otolaryngology Head and Neck Surgery at the University of Toronto. She is the director of the cochlear implant program at the Hospital for Sick Children. She has a clinical and surgical interest in disorders of the external, middle, and inner ear, including hearing loss, and she's an expert in vestibular dysfunction. Her research interests include vestibular imbalance, function, and dysfunction in children, and its association with hearing loss and cochlear implantation. And so without further ado, I'd like to invite Dr. Cushing to speak and remind you to put any questions that you have in the Q&A box.
Well, good morning, everybody. I am overwhelmed. This is such an amazing experience, and I'm so excited that I get to go first and welcome you all into my home this morning in Toronto, Canada. And so I'm going to share with you some of the work that we've been doing at Sick Kids with respect to our children with sensory neural hearing loss. And hopefully, regardless of the systems that we come from and where we come from, there'll be some lessons that we can each take home. I have a few disclosures. And I have an amazing, amazing team at the Hospital for Sick Kids whose tireless work is what I'm going to present to you today. So all of us in pediatrics, and we're really going to focus on children, have a very important responsibility, because whatever we do or what we don't do to children, whether that be take out their thyroid or give them a cochlear implant, is going to alter their development. And when we think about hearing loss, these children are building the brain in the presence of a sensory deficit. And so it's an immense joy, but also that immense responsibility in terms of what we do and what we don't do for these kids, and also when we do it. And that's going to be part of the focus for today's talk. Now, there is an immense amount of data that tells us that deprivation is not good for the brain. Any day with deafness is a bad day. And when we think about our capacity to intervene, likely the studies from Australia are the ones that have the longest outcomes, but continue to clearly show that younger and younger is better. And I'll point you to the last point on this slide, and that is, as they follow these children out, all of whom had the privilege of being implanted early, what we see is that whatever delays they had at 3 years, they carry with them until 9 years. And they likely are going to carry with them until 22 or 50. And so it really creates the impetus for doing whatever we can as early as we can. Now, this is a snapshot of our cochlear implant program at Fit Kids over the years, and so that you can see that how it's grown. But what I want to point out with much pride is that over the last several years, we've added an additional category of children under 9 months of age. You know, and I'll acknowledge, and probably should have in my disclosures, that I practice in a place of privilege in Canada, an envelope-funded healthcare system that does allow equitable access. But there's challenges with that. And I can appreciate that those of you from all over the world may not come from such a place of privilege in terms of access to care for families. But I suspect we have more similarities than differences. And so we could focus on these kids and pat ourselves on the back that we're doing a great job. But what I want to focus on today are the children who end up in these other boxes, the yellow, the teal, the blue, who should have been in this box. To look at where do we fall short for these children who come to us for help in building their brain, and how do we do better? So there are lots of steps to getting a cochlear implant when you present with a baby. And here's an example. These are all the steps associated with it. It's okay if you can't read the font. It's just that there's lots of them. There's lots of hurdles for families to jump through. And what's on this axis is babies who were implanted early and babies who were implanted late. And what you can see is that everything else falls with additional delay. And when we looked at the reasons for the delays, there was lots of them. And I think many of these will be familiar to people, regardless of where you're practicing and what resources you have. And so we wanted to look at how we can manage some of these challenges for families in order to get babies what they need earlier. So the question for today is, does knowing the etiology matter? And many times you'll hear from surgeons, probably even myself at one point in time, that it's not going to change what I do. It's not going to change which implant I use or which hearing aid I use. But today I'm going to try and convince you of the opposite. And so if we look at what we have in our toolbox, and all of our toolboxes are going to be a little bit different, but here is the complete set of tools: genetic testing, imaging, and other tests. So let's first focus on genetic evaluation. Now, in Canada, we have the privilege of having, since 2019, been able to do universal hearing loss risk factor screening that includes genetic screening. So every baby born, regardless of whether or not they've passed or failed their newborn hearing screen, gets genetic evaluation. It's pretty exciting to be part of this program. And we started small. These are the genes that we chose, and it's 22 variants in 2 specific genes that are the most frequent determinants of hearing loss under 5 years of age. We started with really significant truncating mutations, and more recently, we've moved on to non-truncating mutations. And here's what it looks like. I put sort of our size and population just so you can compare it to where you're from. But what we can see, and what I want to point out in this slide, is that we've tested just under 500,000 babies. And the consent rate, because this is a consented process, was almost 100%. So families did not mind universal genetic evaluation, and that might come as a surprise to people. Let's delve deeper into these children that we identified. So the first part is that the detection rate was pretty high when it comes to screening compared to other things that we do. And if we then move down, and I'm just presenting a synopsis, this paper just got accepted, we are looking at, again, these children here, many of whom did not get a universal screen and some of whom passed. So we're picking up babies that wouldn't have otherwise been picked up. We're also double screening some of them. So the rates of hearing loss were quite high in the truncating variants and a little bit less high in our children who had truncating and non-truncating variants. So that's the kids with no permanent hearing loss. So what does this mean for that timeline to treatment? What we looked at was a group of children with congenital bilateral deafness, some of whom had a negative etiologic screen and those who had a positive etiologic screen. And here's what we saw. They got to everything quicker. The delays were less because only 1 in 15 babies in Ontario who screen positive for hearing loss actually have permanent hearing loss. But these babies with genetic risk factors absolutely do. And so they got moved to the front of the line. And so it was a way of not increasing the resources needed to require, but rather streamlining the access, which gave these babies an earlier chance at building a better brain. Now, ours is not the only study that shows this. And again, this is some beautiful data looking at hearing aid use And it's more likely that families will use hearing aids if they have a genetic diagnosis. And so, again, I think we need to revisit the question of it doesn't change what I do. And consider what the impact of knowing the genetic etiology is. The other thing that we're excited about as we move into new treatments, that is gene therapy. And every gene therapy is going to require an accurate and early diagnosis. And so I think more and more, knowing the genetic underpinnings is going to have value. Now let's move on to the second tool. And we're just going to stop here briefly because this is an example of resource utilization that we learned. And so it used to be that we did CT and MRI. And you can see that often in our algorithm, it happened just before the child got implanted. And that's because we really struggled to manage these waiting lists for children. And so what we did is we looked at this and we tried to come up with a less resource intensive plan that didn't compromise clinical care. So we used to have a CT and MRI on everybody. Then we developed the Sick Kids Imaging Protocol, and Jennifer Thu, who's one of my colleagues now, did this work when she was a resident. And now what we do is every baby gets an MRI, and we aim to do it as a feed and sleep if they come to us before 6 months of age. And screening has helped us for that genetic screening. We add a CT only in these scenarios, probably not a complete list. People in the audience might think of some other reasons, but if there's meningitis or a temporal bone trauma, any significant anomalies, so not IP2s or Mondini's, only with very, very syndromic and abnormal cochlea do we add the CT. And when we look back, we only do that 10% of the time. We also looked at how can we get these babies into the scanner without sedation. And initially our MRI techs really didn't think they were very good at this. So we said, give us the data, let's measure it because we think you're better than you are. You think you are. And so we did, and we looked, and the bottom line here is that our MRI success rate for feed and sleep was 88%. And so I think that continued to give them the confidence to do that. So the final tool in our toolbox are these other tests. And for that, to me, it means an assessment of congenital CMV. So let's finish by talking about that etiology. It's very common. It creates immense sensory deficits in both parts of the inner ear, so cochleovestibular loss. It's challenging to diagnose for many reasons, and it leads to progressive disease. So these are children who are particularly at risk of delay. They end up in those categories of children who should have been implanted early but got implanted late. The other thing is that it's treatable. And most people, when they consider treatment, think about what our infectious disease colleagues can do. But I would hazard to say that the efficacy of early amplification may be even more effective in reducing developmental delay than valganciclovir. And so that's just something to consider in terms of the role we can play in these children. So this is what happens to hearing over time. This is a survival curve of hearing. And in blue, we have children who have asymptomatic CMV. So these are not our very affected babies. These are babies that would be picked up with a screening program. This is data out of Texas, and it's probably some of the most beautiful data out there with CMV. In red, we have normal hearing children. And so let's look at what are children without CMV. And this is the prevalence of hearing loss over time. So what we can see is that survival curve of hearing loss is very steep. They're often born with hearing, but lose it within the first year of life. And there is a recipe for delay. And so again, along with the genetic evaluation, we were in a position, again, of privilege where we were able to start a screening program back in 2019 that was universal. And this is our 4-year data. And what we can see is that we identified a small number of children with hearing loss, but more importantly, a much larger cohort of children with congenital CMV who are now being actively followed so that when they develop their hearing loss, we can intervene in that moment and help them to build the best brain. These are the characteristics of those children who presented with hearing loss. And it just points out another feature is that many of them have unilateral deficits that may go on to be bilateral. And this overlaps with other studies we do. Again, we have the resource and privilege to be able to even consider implantation in single-sided children. But what I want to point out in this slide is how many of them have congenital CMV. And that's very important. And here's the reason why. Is that when we look at babies who are born with congenital CMV and have a profound unilateral hearing loss, we had 41 of them. And we followed them over a period of nearly 12 years. What we saw is 65% went on to develop contralateral hearing loss. And so really, we are trying to prevent over time bilateral or provide bilateral access to sound. So these children are a special group to consider in our single-sided deafness population. When we look much in the same way that we did with our kids with genetic hearing loss, those that were coming with congenital single-sided deafness that had a negative etiology versus a positive etiology, primarily being CMD, what we saw again is they got everything earlier. It just allows us to prioritize within a resource-limited system. So in summary, solving for the why of etiology can have a huge developmental impact because early identification remains the foundation of good treatment. And our diagnostic systems evolve. They're driven by therapies as we start to think about genetic therapies, but they also drive therapies. And the final take-home point really is that programmatic efficiencies are important and they require measurement. And that's data that we all have access to. And I encourage you all to reflect on the things that you have the ability to make better in your program so that together we can build better brains. Thank you very much.
Thank you very much to Dr. Cushing for her excellent talk, highlighting what's going on in Ontario, Canada. I think actually we could learn a lot from that. Even in Nova Scotia, I'm on the coast of Canada, and there's lots more that could be done. I would next like to invite Dr. Sam Daniel to upload his slides. Again, my pleasure to introduce a Canadian colleague. Dr. Sam Daniel is the chair of the Department of Pediatric Surgery at McGill University and the surgeon-in-chief at the Montreal Children's Hospital, McGill University Health Centre. He is a professor in the departments of pediatric surgery and otolaryngology head and neck surgery, and a senior scientist with the Child Health and Human Development Program at the Centre for Translational Biology. A specialist in pediatric otolaryngology, Dr. Daniel focuses on such disorders as open and endoscopic airway surgery, dysphagia, salivary gland disorders, and hearing loss. He is currently the president of our Canadian Society of Otolaryngology Head and Neck Surgery. And again, it's my great pleasure to invite him to speak now.
Thank you so much. The pleasure is mine, and as the president of the Canadian Society, you're here to serve others, and it is an honor and privilege to really connect my Canadian constituents with the international community. And I'd like to thank Dr. Elise Graham for her leadership as the president of the Women in Otolaryngology section of our society. An honor to be with our panelists and always tough to follow Sharon Cushing, who's such a great presenter. Today, what I'd like to share with you, my approach to bone-anchored hearing aid implants in terms of options for my patients. And options for my patients, some of you know I'm a professional certified coach, and I consider myself a coach for my patients to help them navigate what are the options, because this maze can be complicated, as many of you know. I am funded by several research grants for McGill Laboratory and a multi-center clinical trial with Oticon. And the program for the McGill Atresia Microtia Clinic is now over 20 years old. It does provide longitudinal personalized interdisciplinary care to those patients, and we continue following them in the institution throughout adulthood, which allows us to see their evolution and the evolution of their needs. It is teamwork. And I'm very grateful to a terrific and wonderful team I work with that comprises a number of folks, including surgeons that work in on the reconstruction for microtia cases, as well as the hearing restoration surgical team, which does implants or atresioplasty surgery, audiologists that are so important and vital in the counseling of patients and their selections, as well as nurses. I'm also proud to have a terrific team at our research lab, where we work in bringing clinical questions to the lab to make technology better serve our patients, particularly areas of research we're working in is the integration of bone as well as different diagnostics for hearing loss. Just back to some basics, we're talking here about using the bone conduction mechanism to transmit energy directly to the cochlea. So these implants are mostly useful in children and adults with congenital ear deformities, those with chronic ear infections that cannot wear hearing aids, as well as select patients with unilateral profound hearing loss. For example, a teenager I implanted recently who had cochlear nerve absence on one side and failure with conventional hearing aids. As you see, so many choices, so many options for patients, and looking at our international communities, some of these are not available in every country, hence the importance of mapping for our programs what is available for our patients so that we can offer them the best. And also not to forget to advocate for these patients, because when I started my journey, I had very few options, and it's thanks to terrific mothers and families that helped me fundraise and advocate for their children that we now offer a panoply of options. And I'd like to divide these options into skin drive options, where the energy is external and has to go through the skin. Therefore, there is one of the drawbacks is attenuation in gain, particularly in the high frequencies, as the energy has to pass through hair, skin, and tissue. And these include conventional headband or eyeglasses that some rely on pressure, like the sound arc, or headbands. We also have something very useful, the adhere implant, relying on glue. Passive transcutaneous, where you have an implanted magnet, such as Sofono or Baha Attract. And I know these are available in many countries. They are still used despite the disadvantage that I mentioned. It still makes an enormous difference for the quality of life of many patients around the world. My preference is for the direct drive when that is appropriate. Obviously, skin drive has its role in many patients, and I still use it for some, but I do prefer the direct drive, and in that we have two main arms, percutaneous, where, as you see below, the implant traverses the skin, so there's the skin is pierced. Hence, sometimes the challenges with the soft tissue and the skin. And in that category, you have Baha Connect and Ponto as some of the options. And my really go-to these days is also the active transcutaneous implanted transducers, which have enormous advantage in that the energy is transmitted directly from the bone, and there is no breach of the scalp or the skin and tissue, therefore less risk of inflammation, infection. And you can see some examples that include BCI 602, OSIA, which is what I use mostly, and we have an expert on the panel, Dr. Sharon Cushing, who's published on OSIA, a terrific series I invite you to read in the literature, and Santio, which is the one of the latest options and has the advantage of being smaller. I'm going to walk you through these options in terms of what guides me for each patient. And for me, it's about looking at the patient's goals. What is their goal? What would they like to achieve in terms of hearing, in terms of their quality of life, in terms of what is possible for them? For example, a patient with juvenile arthritis that has difficulty using their hand, well, I will have to factor that into consideration in terms of choices. And that's hence looking at balancing three factors: the patient factor, such as biological issues. Maybe the cranium is not symmetrical. Maybe there's no place to put a larger OCA implant. What is their preference? What is the quality of life? What is the cost of the device? And I always advocate to help ensuring that these factors are addressed. Looking also at the device factor, what is the power? Is there a magnet? Well, if the patient has to undergo regular MRIs, that is something important in the equation. And what are the limitations of the device? Some patients would like Bluetooth, others have specific requirements. And how long do the batteries last? And is it within their means to obtain that? The system factors, again, access to technology and team experience. And for me, this is an area where it's important to advocate for continuing professional development, ensuring that our team is always up to date with the latest in technology and offering it to our patients. Counseling family is crucial, and we spend a lot of time with them. We ensure we have models. We want them to try these devices on the models, touch them, look at them, understand all the implications, and that's crucial. So things have evolved tremendously. When I look from the beginning of the percutaneous, we're going more and more minimally invasive. And if I look back and reflect my first patients, we used to remove all the soft tissue, then take a skin graft somewhere else, so from their forearm or inner thigh, and that was very painful to them, and bring this skin graft directly onto the bone. We don't do this anymore. We used to do a two-stage procedure where we leave a sleeper for a few months, come back 6 months later, ensure it has integrated. We don't do that anymore. Then we move to different techniques. I'll spare you upper flap, lower flap. And here you see a linear incision where we make multiple drillings to find the most appropriate. And we've moved away from that. I was fortunate in our program in Montreal, where I've implanted the first MIPS in North America. And I'm grateful to this wonderful teenage girl who agreed to do it awake. And you can see her here in the procedure where after local anesthesia, we punched a hole through the skin, put a tunnel to drill through for the MIPS, and then drove the implant. So no incision, no sutures, just a punch directly to the bone. And all of that was done awake under local anesthesia. And you can see her beautiful smile at the end of the procedure. Advantages of the minimally invasive ponto surgery is a decrease in surgical duration, as we've shown in publications. The technology is external. What does it mean? If there is an upgrade in the device, it's easier to change than when you have an internal device where the technology entails another procedure. If there's a technology upgrade, less invasive in terms of dissection, area of numbness, hematomas, pain. After speedy post-op recovery, I had a patient go regularly to their activities the next day, and it can be done under local anesthesia with the appropriate patient. The issues with percutaneous devices, as we've shown in one of the publications, is skin reactions, which varies in the literature. Luckily for us, it's less than 3%, but it does sometimes create problems where there could be skin overgrowth, need for revision surgery, recurrent infections. Particularly, we've shown that children with syndromes are more prone to having a grade 4 Holgers. And another barrier to the percutaneous, and this was a study by Dr. Zawawi in our group at the time, where 10% of candidates refused implants for cosmetic reasons, even though they were terrific candidates. Another study by Aaron, a PhD in our lab, showed that trauma is an important factor for loss in children, and you can see that a lot of these happen during sports, fall in the playground, and other activities. The mono procedure is the latest that we're using in adolescents and adults. And what is new about it is that it's only one drill directly. So there is no need for a widening drill, just going as a one pass. And you can see the shape of the drill that allows that. Exactly like the MIPS, we place it straight into the bone through a punch in a working channel. Moving quickly to the active transcutaneous systems, you can see that clear advantages in the better quality of sound, less transcutaneous reactions. There could still be pressure on the skin in rare cases. Dr. Cushing has published a great series, as I mentioned, on children as young as 5 years of age. I implant young children as well. The youngest was 4, almost 5. There are some issues that can be present with it, and that it's more costly. The monopolar cautery has been reported to perhaps damage the implant in some cases. In rare cases, they could be hematoma, magnet displacement, infection. One issue is the MRI imaging artifact. And I invite you to look at this great publication where you see that osea with magnet, there was some distortion, an artifact, which makes it difficult to see parts of the brain. The same with bone bridge, and hence the need to remove the magnet in some cases, even though the magnet could be safe in the MRI. We've evolved even for this surgery from to go to minimally invasive, whereas before we used to have a large incision, as you can see, shave the head in the first patients, plan some space here for the future reconstruction. We've moved to minimally invasive procedure, and that was work done by our fellow, Dr. Al-Nouri. This is called the MOSIA, and you can see the publication in laryngoscope, small horizontal incision right over the implant. What's different about it is the biplane dissection, and at the end we use the endoscope to position under endoscopic visualization. We position the implant at the end of the procedure, and I'll just show you. This is the implant through the incision. This is the endoscope helping us line up the screw. And if you don't have an endoscope to do that, it's not a problem. You can put a tiny suction through the hole and line up the suction with the hole, and then you can secure the implant and close over 2 layers that do not align, so that it decreases the risk of dehiscence. Other transcutaneous devices are the BCI 602, which has some flexibility, and the latest addition is the Sentio, which is the smallest implant that is transcutaneously active, has a flexible neck, and has this nice band that you can position in different orientations with self-drilling screws. Some report from the analysis of complications of the active bone conduction implant. So device malfunctions When it's internal, it is problematic that you have to change it. Luckily, it is rare. Infection, extrusion of the device, and pain. So in conclusion, there are several solutions to benefit from bone conduction pathways. Let us all be coaches and advocates for our patients to decide on what is best for them based on what is available to us, while advocating and encouraging our teams to open up to all the technologies available. The major advances have been the minimally invasive percutaneous, the minimally invasive transcutaneous, the one-stage technique, use of local anesthesia in appropriate candidates, and obviously active implants. Thank you, and it's been an honor and a real privilege to be here, and great thanks to Dr. Rahul Shah, who allowed for this historic venue to happen today.
Thank you so much to Dr. Daniel for sharing your experience with us. I just want to remind everyone again and thank those who have already been using the Q&A section, but panelists are answering the questions as we go to some degree, and some will be answered live as well. And I'm going to pass it along to my colleague, Dr. Chelius, to introduce our next two panelists.
Thank you very much, Dr. Graham. Although I'm going to be headed to do an on-call mastoidectomy in a couple hours, my core practice is in pediatric head and neck surgery. And so it is a true honor to introduce our next speaker, Dr. Vincent Couloigner. Please go ahead and load up our slides. There we go. Dr. Couloigner is the head of pediatric ENT department in Necker Pediatric Hospital, Assistance Publique, Hôpitaux de Paris, Paris Cité Université. He is Secretary General of the French ENT Society and head of the Scientific Committee of the European Society of Pediatric Otolaryngology. His field of interest and specialization in pediatric ENT are head and neck tumors and malformations, skull-based surgery, robotic thyroid surgery, sleep apnea, and emergencies. We are honored to have you present to us today. Thank you so much.
Thank you very much, Daniel. It's a real honor and a huge pleasure to be with you. Really, it's amazing what you are organizing. I'm very enthusiastic to participate. So I will talk about skull-based pathology in children. No conflict of interest to disclose. First, a little bit of literature about these pathologies. And first, anterior and middle skull base. I found a few series in the literature with more than 50 children per series included, and publications that are less than 10 years old. And so the diseases that you can find is mainly craniopharyngioma, and then you have pituitary adenoma, Radke cleft cyst, clival chordoma, and also encephalocele, fibrous nasopharyngeal juvenile nasopharyngeal angiofibromas, trauma, bone diseases, and tumors. Regarding the procedures which were performed in these publications, about 2/3 consisted of gross total resection. Then you had the subtotal resection in about 20% of cases, and more rarely partial resection, biopsy or fenestration of the lesion. Redo procedures were necessary for persisting disease in 7 to 27% of cases. Of course, these percentages varied highly as a function of the type of disease. For instance, it was more frequent in case of clival chordoma, which are very difficult to remove in totality, and also it depended on the goal of the surgery. Regarding complications, it was highly dependent on the type of disease also, and on the type of surgical procedure. CSF leak was rather frequent, especially for clival chordoma, and also for some craniopharyngioma. The frequency ranged between 2 and 20%. You also had some cases of meningitis, of diabetes insipidus, and hormonal disorders. Every time, of course, you were close to the pituitary gland, and if the gland was damaged, you had this kind of problems. And more rarely, you had some cases of hematoma or hemorrhage. Lethal cases were extremely rare, fortunately. We submitted recently for publication our own series. We excluded children with previous surgical treatment of the disease. We had 75 patients, 123 procedures, and the mean follow-up was about 100 months. So as you can see on the first line, we had 55% of craniopharyngioma, 20% of adenoma, 8% of Radke cleft cyst, and 5% of chordoma. On the right column, you can see that we performed a gross total resection in 24% of patients and a near total resection in 45% of patients and partial resection in 24% of patients. We had to do an additional procedure in about 43% of patients. So you see it's rather frequent. And it was mostly because of residual or recurrent tumor that we needed to operate again. Regarding complications, we had 10 CSF leaks, which is about 13%, 5 meningitis, which were observed only for craniopharyngioma, 5 diabetes insipidus, one transient visual loss. It was during craniopharyngioma with a supradiaphragmatic extension, and we put a graft pad which compressed the optic chiasma, and when we removed the graft, the vision became normal again. We had unfortunately one stroke during the removal of suprasellar craniopharyngioma invading the hypothalamus, and we didn't have any lethal issue in our series. Regarding CSF leak risk factors, we only found one significant factor, which was the existence of intracranial hypertension before surgery, and we were almost significant regarding the suprasellar location of the lesion. Regarding the literature for lateral skull-base pediatric diseases, I only found one publication with a number of patients included, which was over 50. It was an Italian team. And as you can see, diseases were mainly cholesteatoma, schwannoma, and cholesterol granuloma. There were two dead patients due to the evolution of the disease and not to surgical complications. And the complications were mainly abdominal hematoma at the level of the harvest of the fat graft, and infection also of the fat graft. So not many complications. So now I'm going to focus on some general considerations. First, you have to be aware, of course, in children to be careful not to use too high doses of lidocaine, of topical lidocaine, which can lead to seizures, and also lidocaine can cross the internal orbital wall and induce a transient mydriasis, which can be rather scary. Regarding the diagnostic workup, you have to limit as much as possible the CT scan related irradiation, of course, as you know, and you also especially in adolescents, you have the frequent problem of dental appliances, which make difficult to interpret MRI images. Regarding biopsies, mainly you have to do biopsies before surgery when you have an image consistent with a malignant lesion, when there is a solid component, when you have an infiltration of adjacent tissues, bone destructions, when you have no obvious orientation toward a particular benign etiology. Arguments against biopsy, when you have obviously benign lesions like cysts, when the lesions are connected to CSF, of course, in order to avoid CSF leak. When you have highly vascularized lesions of such as juvenile nasopharyngeal angiofibroma, when you have very deep masses reachable only through complex invasive approaches, and when the lesions are easily resectable with satisfactory safety margins and limited functional and cosmetic burden. In that case, you may be allowed to go directly to surgical removal. Another consideration in children is that you have a very low blood volume. You have also a skull base which is rich in bone marrow. So you have to thoroughly monitor the blood pressure and the plasma hemoglobin concentration. And you must, during the surgical procedure, be very careful about the local bleeding. You have to use coagulation, surgical hemostatic agent, topical vasoconstrictors, like adrenaline-based products, and everything you can do to reduce as much as possible the local bleeding. Another issue is in infants and toddlers, as you know, bilateral nasal obstruction induces dyspnea. The toddlers don't know how to breathe through their mouth, so you have to avoid at that age postoperative. You have to use, postoperative stent with hollow tubes and avoid nasal obstruction, of course, by stenting the nose. You also have to try to prevent Dimachkieh, especially in young children. So very often I use at the end of the procedure a elastic sheet that I suture to the septum in order to avoid the Dimachkieh. And apart from very extensive surgeries for tumor resection, there is probably no impact of this surgery on facial, nasal, and cranial growth, provided that the anterior part of the nasal septum is respected. There is no lower age limit for endoscopic transnasal approaches or for nasal septal flaps. So you can operate neonates without any problem, and you can use these flaps also. Another issue is the development of nasal and paranasal cavities. The piriform aperture reaches its adult size at the age of 9 years, and it goes from 17 millimeters in toddlers to 22 millimeters by the age of 9 years. Another particularity, of course, is the development of paranasal cavity. As you know, especially, there is no frontal sinus before the age of 6 years. And the ethmoid are already present at birth, and the maxillary and the sphenoid, the sinuses, are extremely small in young children. Another point is that you have a progressive ossification of the roof of the nasal cavities and of the ethmoid up to the age of 2 years. This ossification goes from lateral to medial. Here you can see a nasal glioma. I thought there was a connection with the anterior coronary fossa, but there was cartilage here actually, and it was just this aspect was just due to the progressive ossification of the nasal and ethmoidal roof. Regarding the intercarotid distance, at the level of the cavernous sinus, there is a reduced distance in young children, and this distance reaches it at its adult dimension at the age of 9 years. Where at the level of the superior clivus, this intercarotid distance does not change with age. So because of this progressive development of nasal and paranasal cavities, it's important to thoroughly analyze the anatomy of the paranasal sinuses before surgery. And also it's very useful to use image-guided surgery, particularly in case of poorly or non-pneumatized sphenoid bone, and in case of lesions located close to the carotid artery and to the cranial nerves. Another consideration regarding tumors, surgery is the usual treatment for benign tumors, and you have to know also that some benign tumors can stop growing spontaneously, such as in cherubism or melanotic neuroectodermal tumors. So sometimes you can avoid performing invasive surgery and just wait for the lesions to stop growing. Regarding malignant tumors, the benefit-risk ratio of surgery remains uncertain, and the treatment mostly relies on chemotherapy, radiotherapy, and targeted therapy. Surgery must usually take into account the initial extensions of the tumor, and reconstruction by vascularized free flaps is often necessary. The choice between external, endoscopic, or mixed approaches depends on the tumor's aggressiveness and extensions, as well as on team's experience. And of course, multidisciplinarity is essential in both the diagnostic and therapeutic phases, with oncologists, radiologists, pathologists, and several surgical specialties, ENT, maxillofacial, neurosurgeons, and plastic surgeons. Now some examples. Nasal encephalocele, as you know, they are usually treated by endoscopic approach. I will not go into details, but mainly you can use a lot of sealing materials. You can use fat. You can use the terminates with both the mucosa and the bone. And you can put these grafts whether above the roof of the nose and of the ethmoid or below it. Usually you put below it. It's called the overlay technique. It's a rather simple surgery with a very good outcome. You have to perform a long-term surveillance, however, because you can have delayed recurrences. Here you can see, for instance, a nasal encephalocele. You progressively remove the encephalocele with coagulation and micro scissors, and then you can see here the little bone defect that you plug, that you seal with a turbinate with bone and mucosa of the middle turbinate. And then at the end, I put some Surgicel and some glue to seal. Sometimes the defects can be too large, and in that case, you can be obliged to perform a neurosurgical approach, subfrontal approach to seal the defect. Nasal dermoid cyst, another quite frequent example. Usually you have a little fistula somewhere on the midline, on the nasal projection. And you can see that you very often have several cysts, several associated cysts. And so you do perform an incision right in front of the fistula, and then you follow the lesion, which often goes under the nasal bone, and you have to drill and use the endoscope to follow the lesion, until you arrive to the higher cyst in proximity to the anterior cerebral fossa. And sometimes you can be obliged also to do an open neurosurgical approach when the cyst is really too high, as you can see on the right. Craniopharyngioma, we have two different situations. Whether the craniopharyngioma is infradiaphragmatic under the cellar diaphragm, and in that case, you can treat it endoscopically through a transnasal route, as you can see on these pictures. You have you open the sella, you open the wall of the cyst, and then you have this yellow liquid coming out of the craniopharyngioma, and you remove progressively the wall of the craniopharyngioma using forceps and curettes, and at the end you try to let open the opening of the wall to avoid recurrences. Instead, when you have a supradiaphragmatic extension of the craniopharyngioma, generally, at least in children, we prefer to perform open approach. You have various approaches: pterional, subfrontal, transcallosal. And an important point is that you have to avoid removing hypothalamic extensions, otherwise you will have big collateral effects on a cognitive point of view. And also, these children have hyperphagia if you remove too much hypothalamus. So we prefer to let this extension and then do a proton therapy if necessary. Juvenile nasopharyngeal angiofibroma, I will not insist. You have, of course, to do preoperative embolization. You usually remove them endoscopically, and sometimes when there is too large extension, intracranial extension or lateral extensions, you might be obliged to perform open approach. Now, just a few examples of benign tumors that you can remove. I will not insist because you have a lot of them. Most of them can be removed endoscopically. We sometimes also perform removal of malignancies even though, as I said, it has still to be proven that you increase the survival with surgery as compared to simple chemotherapy and radiotherapy. Here is a little Astray. She had rhabdomyosarcoma, as you can see, at the level of the middle skull base. And we did both a neurosurgical approach to drill the greater wing of the sphenoid, and an endoscopic approach to remove the lower part of the tumor. Here you can see that the neurosurgeon perforates the inferior part of the sphenoid wing before drilling it. And we use generally latissimus dorsi flap for the reconstruction. Another case of rhabdomyosarcoma, a very extending one, which was centered in the intratemporal fossa. And after neoadjuvant chemotherapy and before radiotherapy, we performed a large removal. In our series, which now is about 45 patients, we have 86% of survival at 5 years doing this intermediate surgery. I think it's another example of bone disease. It's a fibrous dysplasia of the sphenoid bone with compression, bilateral compression of the optic nerve. And as you can see, we used image-guided surgery, which was absolutely essential to see to properly see where the nerves are. And you can see the nerve, which is well decompressed. And we had a good recuperation, a good recovery of the visual acuity in this patient. You can also, of course, have trauma, as in this Iris, is this girl, 7-year-old girl. She had a trauma while skiing with nasal, orbital, and anterior skull base fractures. And we had to do open approach, both at the facial level and a subfrontal approach to repair the cranial base defect. And finally, also sometimes you can do surgery for infections. Here you have, for instance, Denisa, a 7.5-year-old. She had a frontal sinusitis with epidural empyema, and we performed endoscopic surgery. We drilled the posterior surface of the nasal bone to properly see the frontal sinus. And then, as you can see, we had some pus which came out, and we opened the posterior wall of the frontal sinus and drained the epidural empyema. We used the suction catheter here to try to drain the whole empyema. So in conclusion, as you can see, you have very numerous skull base diseases in children, such as malformations, tumors, infections, inflammations, trauma, bone diseases. The critical point is train multidisciplinary teams. Regarding tumors, there is a growing role of genetics, both for diagnosis to diagnose syndromes and for treatment, especially regarding targeted therapies, which are developing extremely quickly. And it's even valuable for benign neoplasms. And regarding surgeries, so you can choose endoscopic, external, or mixed approaches, and you have to take into account some pediatric specificities, such as there is no age limit, but you have to adapt your instruments, your procedures. You have to avoid repeated CT scans. You have the issue of dental appliance for MRI, and you have to take into account of also the development of nasal and sinus cavities, facial growth, and a reduced blood volume. Thank you very much for your attention.
Merci, Vincent. Thank you so much for the presentation and for teaching us all. I'll invite our next presenter to load up their slides. It is my privilege to introduce Dr. Amy Dimachkieh. Dr. Dimachkieh is a pediatric otolaryngologist at Texas Children's Hospital in Houston. She has subspecialty training in pediatrics as well as head and neck oncology, and she cares for children with tumors of the head and neck, in addition to her general pediatric otolaryngology practice. Her research interests focus on pediatric thyroid disease, the multidisciplinary of pediatric head and neck tumors, surgery quality and outcomes. Dr. Dimachkieh, thank you so much for being with us.
Thank you so much. I really appreciate the invitation. I'm overwhelmed to be in the company of such an international group. So thank you so much. I have no disclosures. So we're going to talk about a foundation for thyroid surgery, pediatric thyroid surgery. And then we'll go on and discuss the contemporary controversies in management and things that really excite me about where we are and where we're going. So in general, about 75% of patients who undergo pediatric thyroid surgery are total thyroidectomies. About half of those are split between malignancy and Graves' disease, and then the other quarter are thyroid lobectomies for benign disease, nodules, branchial cysts, things like that. So of the thyroid cancer, it's important to know that while in the United States, the incidence of thyroid cancer in adults is decreasing, the incidence of pediatric thyroid cancer continues to increase. And it's been very steadily, if not increasing in rate of increase over the last 2 decades. So up until the early 2000s. So this, we can see the incidence rates from 2000 to 2018. This is even though there are more stringent FNA guidelines for biopsy of pediatric thyroid nodules, and we've even reclassified one of the follicular variants of PTC to a benign disease, that has not affected our incidence. Our incidence continues to rise. Thankfully, the mortality remains low and survival is outstanding. The incidence appears to be increasing more in females and in adolescents. And so on the left side, we can see age-adjusted rates in the last decade by sex. And then on the right, in females, much more than males. And you can see that age is really peaking in the adolescents. All right, so pediatric thyroid cancer is very different from adult thyroid cancer. And this goes way back to the molecular oncogenetics that is driving these tumors. And so pediatric tumors are more commonly due to alterations and particular fusions in the RET, PTC, and NTRK pathways. And this is compared to the BRAF pathways and point mutations in adult thyroid cancer. This drives the phenotype of the cancer, and so it subsequently drives our treatment options, including the use of targeted therapies and radioactive iodine. So looking at it graphically, we look at pediatrics on the left, and we can see a large percentage of those molecular oncogene drivers are due to fusions compared to our adult colleagues our adult patients on the right side, which are more commonly, again, BRAF, point mutations, and the proportion of fusion mutations is much smaller. Because of these genetic differences, it's driving a different tumor. And so we know in our pediatric patients, the risk for malignancy in any nodule is higher, the risk for extracapsular extension, regional lymph node involvement, distant metastasis, and multifocal disease is much greater in our pediatric patients than adults. Similarly, though, papillary thyroid cancer is the most common of the differentiated thyroid cancers. So same as adults, surgery we know is the mainstay of treatment for pediatric thyroid cancer. However, our younger patients are at increased risk for nerve paralysis and for hypocalcemia. Also, as a consequence, our younger patients are going to live a very long time from the consequences of their treatments and their surgical or any of their treatments, sequelae. This includes iatrogenic hypothyroidism, permanent hypocalcemia, and vocal fold paralysis. So great thing in 2015 is this is the American Thyroid Association guidelines for the management of children with thyroid nodules and differentiated thyroid cancer. A very similar guidelines was published in the European literature. And this has served in the last decade as the foundation for the treatment of pediatric children with thyroid cancer and how we're moving forward in our treatment. And so this is where I want to talk about the meat of it today, and the part that really excites me is that we use the foundation of those 2015 guidelines to do better, right? And so how can we think about reducing the risk of our treatments, which includes considerations for lobectomy, elective neck dissection, and our use of radioactive iodine? And then how do we optimize outcomes, right? We're talking about multidisciplinary care, high volume surgeons, the use of targeted therapies, and evidence-based perioperative guidelines. So we're armed with these guidelines and our new information on molecular oncogenetics, and we want to provide aggressive treatment when needed, but limiting overtreatment when possible. So I want to go through each of these and just kind of hit on them. And so the first one, kind of the easy one for thyroid, is a high volume center. Pediatric thyroid cancer is still a rare tumor. In the United States, it is 0.7% of all pediatric cancers. That being said, we still have a lot to learn about it, and we know that a multidisciplinary and a high-volume surgeon improves outcomes. Improved outcomes are decreased length of hospital stay and improved perioperative outcomes, but it's unclear what the oncologic benefits long-term. Another thing we're still learning is what constitutes a high-volume surgeon. These cohort studies look at surgeons who are doing 9 pediatric endocrine surgeries a year to up to 30 pediatric endocrine surgeries per year. But the consensus is that concentrating pediatric thyroidectomy to a smaller cohort of surgeons leads to better outcomes. The next one is targeted therapies. So this is very exciting, and over the last 5 years, the FDA has approved a number of medications for the treatment of pediatric thyroid cancer. In particular, kind of flashing back to that molecular oncogene driver, is we're targeting those fusions. We're targeting the RET fusions, the NTRK fusions, and the development of targeted therapies. These drugs are much safer than our historic multi-kinase inhibitors. These drugs have less effect on the VEGF pathway, and so patients do much better with them. The ones that we're using most commonly are selpercatinib for our RET fusion positive disease and larotrectinib for our NTRK fusion positive disease. So these drugs can be used in an adjuvant setting. They can be used even in a neoadjuvant setting. And then interestingly, they can be used to improve radioactive iodine sensitivity in disease that is initially radioactive iodine resistant. So I've been lucky with my collaborators here in the Texas Medical Center to be able to use these medications in all 3 of these settings, and I've had wonderful outcomes with our patients here as well. And so you'll see more of this in the future. The next thing we're looking at is the use of evidence-based perioperative guidelines. So this is interesting because we know that children are at risk for hypocalcemia more than adults. Some not modifiable risk factors include Graves' disease, a central neck dissection, and multifocal tumor dissections. And so those patients are at increased risk for temporary hypocalcemia. But modifiable risk factors are preoperative low vitamin D or preoperative hypocalcemia. And so we can use that information to develop perioperative guidelines. These are just some examples of ones that are already published in order to improve our patients' perioperative outcomes. Decreasing blood draws, decreasing length of stay, and generally improving our perioperative care. So those are some ways that we can think about improving our outcomes. And the next thing is considering how can we scale back when possible? How can we reduce the risk of our treatments? So one consideration is in lobectomy. So this is commonly used in adults for T1 and low disease. And so understanding that pediatric patients have a different disease, have a different problem, and they are more likely to have multifocal disease, more likely to have cervical and distant metastases. And so we're trying to identify the patients that might be lower risk. And so our first investigation is which patients are going to have multifocal disease and which patients are going to have lower risk disease. And so looking at a number of patients with T1 tumors, it appears that T1 tumors that are unifocal have a 95% chance of being a unilateral disease. However, those tumors that are multifocal but still unilateral have an increased risk of bilateral multifocality and regional lymphadenopathy. So the jury is still out on this one. We don't have a consensus. Still here with the ATA, our recommendation is for a total thyroidectomy in all pediatric thyroid cancers. But this is very interesting to try to understand which patients might be considered for lobectomy. And I think we'll see a shift here in the next decade. All right, the next controversy, this one's actually kind of my favorite, the elective central neck dissection. So our guidelines, both from the ATA and from the endocrine section of the AHNS, say that elective central neck dissection is an option for patients with advanced primary disease. And this should be balanced with the risk of missing clinically significant disease and then the increased risk of hypoparathyroidism. But the general consensus is that in an experienced surgeon's hands, the risk of an elective central neck dissection is very low. The risk of having hypocalcemia or hypoparathyroidism is still low in an experienced surgeon's hands. But it's trying to balance the benefit of who would benefit from that central neck dissection to reduce the risk of needing revision surgeries or having persistent disease. And so looking at this, there is increased information and data using molecular oncogenetics to try to decide which patients are a low-risk invasive behavior and high-risk invasive behavior. So low-risk invasive behaviors include the BRAF mutations, and then high-risk invasive behaviors are like our NTRK fusions and our RAS and RET-PTC fusions. The last one to talk about today is radioactive iodine. So radioactive iodine is well documented to decrease recurrences and improve recurrence-free survival for up to 50% risk reduction, but this is limited. This data is limited in 10-year follow-up in children. But we know our pediatric thyroid patients are going to live a lot longer than 10 years. And so in some longer studies, we know that radioactive iodine can increase the risk of secondary solid malignancies and hematologic malignancies. And this is more after 20 years survival post-RAI exposure. And up to 6% of solid malignancies and 14% of hematologic secondary cancers can be attributed to radioactive iodine. So we have to be cognizant that we are treating patients that are going to live a very long time. So as we do better in treating pediatric cancer, we have to anticipate the consequences of our treatment. And so in 2019, Science published this really great section of saying we have to look at the consequences. These patients for leukemia, some lymphomas, thyroid cancer, they're going 98% survival at 5 years. But what are the consequences of our treatments? And so I've presented some options here of things that we're looking at and things of how we look forward into the landscape of pediatric thyroid cancer and pediatric thyroid surgery to attempt to do better. These are my collaborators here at Texas Children's, and I'm excited to collaborate with all of you as we move forward. Thank you so much for the invitation. I'm truly honored to be here.
Thank you so much, Dr. Dimachkieh. That was an exceptional presentation for all of us. We want to thank all of our presenters today for their wonderful panels. We have had some excellent questions in the Q&A box, and I'm also grateful to our panelists for all of the answers there. If you haven't looked at the Q&A box, please do take a look, attendees, so you can see some great answers to some questions. With that, I'll turn it over to Dr. Graham.
Great. I'd like to echo the thanks for everyone who's participated and asked questions and our esteemed panelists here. We have a few minutes if you have a few more burning questions you want to put in the Q&A, but we were going to also reach out to our panelists to see if they had any particular pearls, a single pearl for caring for children that you'd like to share for our panelists or for our viewers across the world.
I think, something that I've learned, over time, and this is universally applicable, and especially in the time where we start to think about precision medicine. And the more I think about precision medicine, the less that I actually think it's about molecular diagnostics and fancy treatments, but rather sort of really assessing and meeting the family where they are. And I think we really have to think about a socio-demographic version of precision medicine. And I think my patients have taught me that over time, that when we do make those efforts to reach them where they are physically, emotionally, there's great dividends to be had.
Thank you so much.
Thank you. For me, it's about challenging yourself. It's not because you've always done it a certain way. In fact, what I would invite you is to ask yourself, whatever it is, it applies to everything we do in pediatric otolaryngology, and to say, why not? Why don't I do it differently? And then look at the literature and don't take no for an answer. Always advocate for children and for their families and build connections like the one we have this morning. We're really privileged to have amazing people around this table. These connections only make you stronger and a better surgeon.
Yes, I would be maybe a little bit similar to maybe to Sam. I think one of the most important advice I could give to my younger colleagues is that you always have to, when you have difficult situation, to ask to other people, to ask for their experience and advice. And very often, just as a joke, I say to my fellows that my brain is in my cellular phone, because I always try to call experienced colleagues, and I think it's a very important thing to take the right decision.
Yeah, I would echo that and just say the challenging yourself, as Dr. Daniel said, and then challenging your peers and using the community that supports you. And that is just could not be exemplified any better than the community here today. So thank you. You're always welcome with me, and I hope to see everybody again. Thank you.
I think a lot of our panelists have had questions answered throughout all of the talks, but as Dr. Dimachkieh's talk was at the very end, we've had a number of questions come up specific, and I'll just call out one of them. Dr. Dimachkieh, considering the different presentations for different mutations in pediatric thyroid cancer, would you recommend genetic testing for all patients with pediatric thyroid cancer at this point? What would you say to that at this point?
There are so many levels of that I think we're really pushing the limits. A lot of that, at least, is going to be access. In talking to my peers around the country, molecular testing is not readily available to all patients. And the question is, what do you test? Do you test the tumor? Do you test the FNA? Do you test your specimen? And who is eligible for those tests? I think that the future will demonstrate, but we do not in general use molecular testing on FNA specimens in pediatrics at this time. But I think that's where we're headed in looking at better understanding how that drives the phenotype of the cancer. So I'm interested to see where that's going. I think that is the future of pediatric thyroid cancer.
Thank you so much. With that, we are pleased to turn this back over to Dr. Serna, our international coordinator, and on behalf of all of the panelists, Elise and I thank you for this opportunity. And I believe you'll need to unmute, Maria.
Thank you so much. Thank you for wonderful discussions. Dr. Couloigner, do you still have a comment or last comment?
Sorry, thank you. No, I wanted to ask to Amy something about this specific situation of DICER1 mutations. You know that it's more and more involved in young patients with thyroid disease. And sometimes I must say, I do not know what to do between a lobectomy and a total thyroidectomy. So what would you recommend, for instance, if you have one suspicious nodule on one side, and on the other side, whether you don't have anything or you have very small, gentle nodules?
I think that's a question I ask myself almost every week. In Tumor Board, we have DICER patients. We're currently looking at our cohort. So we've gone back and pulled all our DICER patients and their nodules to understand that. Absolutely. I find that the main driver for my decision is the social determinants of health, as Dr. Cushing is alluding to, is if you don't have a clear answer in the pathology in the patient, then I'm looking more at where is this patient headed? Is it an adolescent who has poor access to care? Are they not going to be able to follow up? Or is it some family where the iatrogenic hypothyroidism would be much more devastating to them than repeated ultrasounds? So unfortunately, I don't have an evidence-based pathologic recommendation, but more using our patients to help guide us in that decision-making when the answer is maybe unclear, which I struggle with this every week.
She's very clear.
Well, thank you so much. I really want to thank the panelists and moderators and the Academy and the Canadian Society leadership for this wonderful Grand Rounds presentations and session. I want to bring up to your attention that we have a next one, Global Grand Round session planned, and it's going to be on advanced techniques in endoscopic sinus surgery. And this is going to be the first time we're going to have a live dissection demonstration. This next Global Grand Rounds are going to be in collaboration with Pan American Association of Otolaryngology and Head and Neck Surgery. And it's also going to be sponsored by Medtronic that we're grateful to provide the cadaver lab for us to do the live dissection and demonstration. So if you are interested, please register at entnet.org/GGR, and hopefully we'll see everybody at the next grand rounds. I also want to invite you to the American Academy of Otolaryngology annual meeting, which is going to be held in Indianapolis. For international participants, if you're planning to come, this is going to be a good time to start thinking about travel arrangements and visas if necessary. And it's going to be in October and from October 11th to 14th. And Indianapolis happens to be my hometown as well. So I would like to welcome everybody to Indianapolis. For international otolaryngologists, we do have some scholarships that are available through the Global Educational Fund. I would like to introduce you to Eugene Myers Global Foundation. And that is offered to otolaryngologists or faculty who are practicing specifically in low-income and low-resource countries. And the applications are being currently accepted, and the deadline is April 14th. And participants can apply for a scholarship up to $2,000. And that can help us offset cost of travel for attending the Otolaryngology Academy meeting, and also participate in observerships in the United States, and some of the access to some of the educational tools, and also membership dues. So again, information is available at entnet.org. We also have international visiting scholars programs, and those are more for junior faculty who are under the 40 years of age or in the first years of practice. And again, it can help offset some of the cost of traveling to the academy meeting and some of the educational activities, specifically observerships in the United States. And again, the deadline is April 14th. You're going to have some options of joining the academy, and there's discounted rates that are available for international participants. And some of this information is going to be emailed to you in the next week or so. I want to specifically emphasize that attendee certificates are going to be emailed to you next week. So you just have to wait for a little bit before you can get some of the certificates. Also, session recordings are going to be available next week, and some of the other communication is going to be also sent out next week. So be on the lookout for that. And again, I want to close the session by thanking all the participants. And Katie, thank you so much for helping organize such a wonderful, again, collaborative event. And again, thank you so much to the Canadian Society, because this is a wonderful opportunity for us to collaborate, and looking forward to further collaborative events. And with that, I would like to close this global grand rounds, and see you next time. Thank you.